Maybe it's not showing. It's not showing us this way.
Okay, now. Are we live now?
Kermit the Frog here!
Okay.
Can you hear me? I hope it's working now, because they just got a great impersonation for free. All right, so I just got the go-ahead. Take 5. Our audio wasn't working, so luckily Karen brought in another computer for us. My name's Dr. Susan Griffith. I'm the pediatric orthopedic surgeon at Bucks County Orthopedic Specialist. We also work out at Doylestown Hospital. This has been quite an adventure. I don't think in the 16 years that I've been practicing medicine and orthopedics that we've ever even remotely encountered something along these lines. And we really appreciate all of our staff and then also our patients on how patient they've been with us in us using different forms of alternative forms of treatment. The telemedicine has worked out well, the video medicine, and people have really been thankful for that. For me, you can't do telemedicine for getting your hair cut. So I am missing getting my hair cut. And then in the beginning, it was kind of cool because, you'd wash your hair every other day. I had the Shakira look going, but now it's like really getting terrible. So I considered cutting my own hair, but then I said, no, I better not do that. I think I'd look more like Joe Exotic, which I'm really not looking to be in the Tiger King realm at all for my hair. So I'm going to hold off on that idea. But we are here for you for emergency visits and to talk you through things and how to manage your orthopedic issues during this time. I want to go over a little bit of pediatric orthopedics, but I want you first to put down your Celsius, and the kids should put away their Easter eggs and their Easter egg or Easter candy, because this is an important topic that people have a lot of questions about. So I want to first start off with going over my training and what makes you a pediatric orthopedic surgeon or specialist. So you go to medical school, you then do your internship and residency in orthopedics. And then after that, you do a fellowship year. And that fellowship year is in pediatric orthopedic surgery. So I did my fellowship at St. Christopher's and Shriners Hospital for Children. I also, in my residency, did a lot of work at DuPont Hospital for Children and have a good broad sense of many ways to skin a cat with pediatric orthopedics. So I really thank everyone that comes to me for endearing your kids in my care. And I really have a great time with them. In fact, I was telling somebody recently that it's hard for me because I'm a handshaker and a hugger, and I can't do either right now. Everybody's got to keep their social distancing. So I feel like a Chihuahua puppy on a SPCA commercial, just kind of shaking behind the chain link fence. So at some point we'll get back to being able to do the things that we like to do and enjoy each other's company. For now, please always feel free if your kid gets injured at home, or if they have an issue that's been ongoing, to give us a call for direction. And we'd be able to tell you whether, you should take them to an urgent care or the hospital. Certainly if there's a deformity after falling, that would be the place to go, even though you do have that risk of exposure. The risk-benefit ratio is much better if you would just go there. But for other things that are not as emergent, you could certainly give us a call. Sometimes we will have you come in to get x-rays or at least direct you in a manner to go to an outpatient facility that would be safe for you to go to for your follow-up care. I have many questions to get to. I'm really glad. It seems like everybody here is interested in this topic. It is a really fun topic. I totally enjoy working with kids, as does my assistant, Alyssa. we really enjoy, working with the kids. The first question is Karen S. At what age should a child be checked and treated for scoliosis? And I got to tell you, this question is asked to me a lot, and I want to give a lot of credit to people that aren't me for identifying this and taking care of this issue. And when I was working at DuPont, there was an initiative for scoliosis that the pediatricians and the school nurses are trained in trying to identify these spinal asymmetries. And so they do a good job for me to start looking at the kids back from birth to be able to determine whether they have scoliosis or they don't have scoliosis, or if they're at high risk. And then we get the appropriate x-rays. For the majority of kids, they start checking around 9 years of age, really honing in, because the most common form of scoliosis is adolescent idiopathic scoliosis. And during growth spurts is when you would notice those types of curves. So the school nurses will check usually 5th, 6th grade, and then early in their junior high careers, they'll also do that. So when I went to Holcomb Middle School, I remember the school nurse even checking me to see if I had scoliosis. I didn't, but that's when they started lining us up and having us, them check our backs and then also our sight. So the school nurses do a fantastic job with that. As far as treating scoliosis, how long do you do surveillance on kids that have scoliosis? I know that was a question that was asked by Mary Kay. The initial onset of looking, again, we're looking at birth. The neonatologists at Doylestown Hospital will check the backs, make sure there's nothing there that would be suggestive of a congenital scoliosis or a neuromuscular condition that might predispose them to scoliosis. So from birth, they do check frequently. And then, at that 9 years of age, they're checking. But then when do you call it quits? When do you stop checking? So for adolescent idiopathic scoliosis, typically we check until they're skeletally mature. And we can look at full-length x-rays and be able to determine that, along with asking about, their puberty status. And when they're fully grown, then if it is a curve that is borderline bracing or surgery, then oftentimes we'll check 2 years after skeletal maturity and then 5 years after that. So the cool thing about that is that I get to know these kids sometimes even after they've had their firstborn, just to check their spines and make sure everything's fine that way. It's very uncommon for kids to require surgery, but it's not never for sure. And bracing is a little bit more common, but again, is uncommon in the nature of how many kids I see on a weekly basis. Most of them require just surveillance. Michelle E, this is we're kind of switching gears here. So Michelle E has a question about fractures, in particular growth plate fractures, and how that might affect the child's growth in the future and how long you actually monitor for that. So this is a question that we're asked regularly, and I really want to kind of back up the horse and talk about what is a growth plate, because if you don't know that, then it's difficult to be able to move forward and have people understand what the need is for monitoring of this. So I don't have growth plate. Randy doesn't have growth plates. Karen don't have growth plates. We're adults. So when you have a baby, those babies are this big, and there's got to be something in the skeleton that'll allow that baby to grow to whatever their adult stature would be. And that's what the growth plates are. So it's special cartilage that's near the ends of each of the bones. And that cartilage has a predetermined length that bone is going to grow, and then it fuses. So the importance of determining those types of fractures can cause issues with long-term growth of the bone. And sometimes if it's damaged in a particular area of the growth plate, it can actually cause angulation of the bones with growth. So for that, it's important that first find out what type of growth plate injury it is. And there is a general classification called Salter-Harris that goes 1 to 5. And then some people even talk about a 6, but traditionally it's 1 to 5. And kind of easy. 1, the least invasive injury to the growth plate, going up to 5, which is the most, which is a compression of the growth plate cartilage that can cause long-term damage and issue. So knowing that, then it tells you we ought to really watch this for a period of time. So we make sure that that growth plate is in a position that allows that to continue growing in a normal way. So sometimes that requires surgery. Sometimes that requires casting. Sometimes it requires activity modifications. Many times it does. Meaning no sports and things that could shift that fracture. And then once that is healed, then we look to see if there is any limb length discrepancy or angular deformity clinically moving forward. And then also look at the x-rays. The x-rays can show that. And if there's question about that, then we'll get an MRI to look at if there's any bony bars that form in that growth plate that could cause angulation or issues long-term. So that is a very technical, at that point moving forward, what do we do with that? That's a really long discussion on what we need to do for angular deformities, limb length discrepancies, and all again determined by their age, their maturity level, and risks and benefits for treating that. So we will follow growth plate injuries, typically that are less severe. They'll have their cast on 3, 4, 6 weeks, somewhere around there. And then after that, the cast comes off. We get another set of x-rays. And then after that, we'll see them in 6 months. And then after that 6-month visit, we'll see them in a year to get another set of x-rays. And then at that point, if those are all good, then typically the patient is out of the woods, typically. So so that's Michelle's E's question. Bonnie D, can you explain what Osgood-Schlatter's disease is? So Osgood-Schlatter's, well, first off, great German names. I mean, come on, Osgood-Schlatter, fantastic. But the Osgood-Schlatter's disease, I never throw that name out there when I'm actually assessing kids. So the patients that know me, they know I go through a whole litany. And what I say is, you know, the growth plate that is below where the kneecap is on the tibia, where the shin bone is, the top of the shin bone, there's a growth plate not associated with the joint. We call it an epiphysis. An epiphysis is a growth plate that's not associated with the joint. And in that area, it's the tibial tuberosity. So we would call this, what's wrong with them, and it's due to growth and activity level that causes abnormal tightness in the leg. We call it tibial tuberosity epiphysitis. So epiphysitis is inflammation or irritation of that. And I'd rather discuss it that way than Osgood-Schlatter's disease, because if you say that a kid has a disease, the first thing they're thinking of is that they have something life-threatening, they have something limb-threatening, they have something contagious, and it's none of that. So after, in the beginning of my career as a pediatric orthopedic surgeon, having multiple callbacks, asking those questions, I've kind of reverted and said, we'll wait to the very end to let them know it's actually a term for this is Osgood-Schlatter's disease. So we just named it to honor Dr. Osgood and Dr. Schlatter. And so the dynamic problem is that the hamstrings get really tight, which is in the back of the leg, because of the growth of the femur. and it makes the front of the leg have to overexert it themselves. And so the quads have to overexert to be able to pull that leg, that knee straight for running and jumping purposes. So it causes abnormal traction at that growth plate. So that's Osgood-Schlatter disease. Again, cool because it's German name, but otherwise it's a very common issue. And there's other areas in the body that have a similar type of problem that way. We name that Epiphysis in the back of the heel after Dr. Sievers, so Sievers disease. If it's in the inferior pole of the patella, we name it after Dr. Sinding, Dr. Larson, and Dr. Johansson, so Sinding-Larson-Johansson syndrome. And, so we just have different guys that we wanted to honor, and we just didn't want to use the Latin names is what it boils down to. So next question. This I think I got into before. Margaret had asked about what should you do if you think that your kid has an injury, what direction should you take? So if your kid is bouncing off the walls or the couch or the bunk beds and they fall and go boom, there's options for you. Because of the coronavirus, we have to weigh, the safety and efficacy of whether to send them to the hospital, whether to bring them into our office, or whether we can just talk about it over the phone or video chat with maybe outpatient x-rays. If there's gross deformity, there's no question. You really ought to take the child to the emergency room for something of that nature. But if it is something where there's no gross deformities that you see, maybe a little swelling, just call our office. We've got people that can help you triage this as far as whether to come to our office for x-rays to rule out fracture, or whether we could do something like a video chat or what have you. So you're not alone. You're not alone in this. It's just we're practicing medicine in a very different way right now. But it's good medicine and it's smart medicine and it's doing things safely. So I hope that answers your question, Margaret. Patty D, am I better off taking my child? Oh wait, this is the same. That was the same one as what Margaret said. Mary Kay and Rebecca N asked the same question. Can a pediatric hip injury present as knee pain? So this is very interesting. So the hip has many different issues that can, depending on age, that can present as knee pain, and it actually be a hip issue. And that's where we'll never be replaced by robots. The physical exam and the history taking are a vital part of this. So if a child is under 2 years of age, and has knee pain, but the knee is working great, but is grabbing for their knee and they're moving their knee fine, there's a chance that there could be a hip infection or what we call toxic synovitis, which has to do with the child having a cold or a GI bug or someone in the family having that in a period of 2 weeks, a month before. And depending on the severity would be whether it's a true infection or whether it's something that's toxic synovitis. The toxic synovitis usually isn't before 2 years of age, so we really think heavily of infection in that age group. But 2 to 5 years of age, definitely toxic synovitis, a very, very common thing that the pediatricians see often. The pediatricians many times are able to triage that very well, and those kids end up taking Motrin and improving. As the child ages, then that hip pain that's referred to the knee can be from other things. So 5 to 9 years of age, you really have to think of Perthes disease. It's called leg calf Perthes. Of course, we have to honor so many people in orthopedics, so we always have to name everybody that had anything to do with the hip. We name it after them. So leg calf Perthes disease, and it's named after 3 orthopedists. And that is where the blood supply to the femoral head is altered, and it changes the shape of the cartilage that caps that bone, and in essence, that femoral head becomes flattened. That is something that typically will present as a limp. And sometimes people will say it's knee pain because it does radiate down to the knee. But actually, when you examine the child, they have restriction in motion of the hip that's even slightly different than the other side. It's of concern. So that's when we get x-rays of the hip, x-rays of the knee, and try to determine that through those x-rays. If there's any question that's above and beyond the x-rays, if there is a high suspicion, we'll get an MRI for kids that are typically, 5 or 6 years or above, because they can tolerate an MRI very well, laying still for that period of time. If the child is 9 years to adolescence and they have knee pain or hip pain that radiates down to the knee and has a limp, then you have to think of slip capital femoral epiphysis. We call it SCFE. You might have heard that. But slip capital femoral epiphysis is exactly what, if I break it down, it's exactly what it says. So essentially what happens is that the growth plate at the top of the femur, the metaphyseal portion or the neck portion, will pull away from the head portion of the epiphysis. So it slips away from that epiphysis. So slip capital femoral epiphysis. So that is something that happens. We see it in very obese children. We see it in kids that are tall and lanky, Nordic European. We see it in kids sometimes that are younger. So I've treated kids with slip capital femoral epiphysis that were 8 years of age. And it's because they actually had an underlying thyroid condition or endocrine condition that created that. And that's a very rare situation, but it does happen sometimes. So those are things that, on exam, we're watching the kids walk in. So many times I'm poking my head around the corner of my little cubby, watching the kid walk in, seeing the kid's demeanor. Are they like wet dish rags, where they just have no expression and just look super, super sick? In that situation, definitely you have to think infection. Are they pretty happy kids and just kind of bouncing in with a little bit of a weird gait? Then those kids, we think of toxic synovitis or even a slip capital femoral epiphysis. Usually the slip capital femoral epiphysis will be a gradual onset. A limp that the parents say, is it getting better? Maybe it's not. That's many times what you'll see with those kids, and an externally rotated gait. And the Perthes kids are very similar to the SCFEs kids, but it's usually a little bit younger than what a SCFEs child, again, 5 to 9 years of age, and with a limp, but not that externally rotated gait that you would see in a kid that has SCFE. So hopefully that answers your question. That's a great question, because pediatric hip is a really challenging diagnosis to make, even for some people that are orthopedic surgeons that don't have that specialty training. Sometimes they have a struggle with that. So it's a great question. Something that is, if you ever have a question about that, I'm happy to start off the conversation with you. Cassandra B has a question regarding hyperflexibility in her child and sitting and sleeping in certain postures, and whether that would affect the child long term. So kids that are hyperflexible oftentimes have certain conditions like Ehlers-Danlos syndrome, or there's many other forms of hyperflexibility in kids. I call it generalized ligamentous laxity. They're very, very flexible kids. Those kids are usually go to gymnastics because they are hyper flexible and they're good at that sport. It certainly, gymnastics doesn't make the situation better, but certain sports that do encourage core strength is helpful. Those kids are more predisposed to sprains and strains than the average Joe. And clinically, I've noticed it taking a little bit longer for them to improve from a symptomatic point of view. So if everybody else, if like say a 6-year-old gets better in Randy just gave me the 5-minute thing, but I think I could go longer, Cassandra. No worries. If if in if they do get hurt, if a 5-year-old gets hurt and it's a sprain, usually in 3 weeks they're feeling absolutely fine, no problems whatsoever, off to the races. That child might take another 3 weeks to get better from that, just to get their strength back because they are so flexible. So really, I haven't seen any issues with their sleeping and their sitting postures long term. They're like kids that go to Cirque du Soleil and are making money that way because they are so flexible and they could do those crazy, double jointed tricks. But that doesn't cause any issues for them long term if they're sleeping on their stomach while they're an infant or what have you. I wish I could be here for an hour with you guys. I'm sorry I don't have my dogs with me. The people that I've done video chats with me, usually they see Minnie, who's my little Chihuahua Toy Fox Terrier mix. She's usually like right on my shoulder, or Charlie Peaches, who's my mini Pomsky. They love to sit there and talk to my patients after their visits. So I don't have them today. I'm sorry. But someday we'll be back together again in our office, but you can always give us a call. We've got multiple specialists in all different types of orthopedic surgery. And if we don't have an answer for you, if we don't have a specialist, we can guide you on where you need to go next even. So, we're very, very good about getting back to our patients. We miss you. We miss our staff. I can't wait to see you guys in the office, but we're going to help you through this trying time, and we're all going to be better for it. So I appreciate your time, and everybody stay safe and healthy, and catch up with you later.